critical care doctors. Hopefully everybody can see my screen. So I work primarily at Legacy Emmanuel Hospital. I do both medical critical care, I do neuro critical care, and I also work on the ECMO service. So today we're going to talk about cardiac arrest. This is a presentation that's near and dear to my heart. So I also serve as the director of our system-wide Code Blue committee. So if you guys ever have questions about cardiac arrest, or you want to get involved in quality improvement related to in-hospital cardiac arrest, I would be the person to talk to. And I really would love to get you guys involved if that's something you want to do. So I know that this particular topic is one that's really anxiety provoking, definitely to new interns, I'm sure, but even new second year residents. It's just, it's a nerve-wracking thing to know that you're going to be responsible for running codes in the hospital. And the truth is, I get that. You guys are going to, you're the most important part of our code response at Emmanuel Hospital and Good Samaritan Hospital. So what I want to try to do today is to give you some information that helps to alleviate some of that anxiety, and also that I can give you some information to demystify cardiac arrest a little bit and try to make it simple in a stressful situation. All right. So our objectives today, we're going to review in-hospital cardiac arrest outcomes. We'll talk specifically about what's different for in-hospital arrest as opposed to out-of-hospital cardiac arrest. We're going to give a simplified framework for approaching cardiac arrest in the hospital. We'll talk about when to stop coding. We'll talk briefly about post-arrest care, specifically targeted temperature management. And then we'll have hopefully some time at the end for questions. So we are gonna try to do, make this participatory. So I'm gonna have some questions, and basically there'll be an A, B, C, D. If you guys can just answer with the letter that of the preferred answer into the chat, just so I know that you guys are following along. Okay. So in-hospital cardiac arrest, why is it important for us to know about outcomes? Well, mostly this informs our code status discussions. So I think it's a nice way to think about, start with the numbers before we're talking to patients. So all comers for in-hospital cardiac arrest, there's 25% survive to discharge, and that's different than out-of-hospital cardiac arrest, which is at about 8 to 9%, depending on the region. So of those 25% that survive to discharge, 1/2 are able to discharge home, 1/4 of them will go to SNF, and 1/4 will go to LTAC. So LTAC stands for long-term acute care. So for people who work here, that's basically Vibra. That 1/4 that go to LTACs also corresponds with the number of patients that do not have good neurologic survival. So again, about 1/4 of those 25% that survive are not going to have a good neuro outcome. And what that means specifically is that they're going to require 24-hour care for all of their ADLs. And then big picture, 50% of those patients who survive are going to be alive at 1 year. So that's 12% overall. This is a graphical representation of a lot of this data, and it also splits the information into the type of presenting rhythm. So as you can see on the top, shockable rhythms have an overall survival in 2017 around 45%. And that differs pretty significantly from non-shockable rhythms. So that's PEA and asystole. Survival for those in 2017 were about 20%. And the data I mentioned earlier, about 25%, is where we stand for all comers. So to recap, of all in-hospital cardiac arrest, 75% die, 12% will go home, 6% to a SNF, and 6% to long-term acute care. So let's start with a case here. You have a 76-year-old man who's admitted with pneumonia. You talk to him and his son about his code status. Patient asks, "What are my chances of even coming back, doc?" And you say, let's try to answer. Good, guys. Thanks for paying attention and participating. You're right. 25%. So then his son pipes up and says, "Dad, you wouldn't want to end up being a vegetable." And the patient says, "I only want to be saved if I can go back to my same quality of life." In that case, you say that chance of survival is so about 12%, meaning that would be the number of patients who survive the cardiac arrest and are able to make it home. So you continue looking into this patient's chart later, and you realize that the patient has a lot of medical comorbidities: CKD, COPD, heart failure with reduced ejection fraction, and coronary disease. Now, each one of these chronic medical conditions will increase the odds of poor survival from a neurologic standpoint. Now, we also know that each of these conditions are additive in terms of leading to worse survival. So what you can say in the case of this patient is his chance of a meaningful outcome would be far less than 12%. And in all likelihood, probably low single digits. So sometimes what I hear from patients is, well, if I'm dead anyway, what's the downside in trying? And I think that they're not wrong in asking that question. And for some people, they may want to have everything done, and that's okay. The way that I tend to answer that question is I say, first of all, DNR status does not mean that we would not treat the patient fully, that we would provide them, in fact, all of the aggressive care that we have available up to the point of coding a patient at the end of their life. I then go on to say that sometimes full code status prevents us from being able to institute comfort-focused care when the opportunity presents itself, so that some dignity might be able to be restored at the end of life, and that one might die not connected to machines. Those two things are important to a lot of people. So in-hospital cardiac arrest is really different from out-of-hospital cardiac arrest in terms of the percentage of rhythms and how they present. So 81% are pulseless electrical activity or asystole, 19% shockable rhythms, VFib and VTAC, whereas about 40%, maybe a little more, are shockable rhythms in out-of-hospital cardiac arrest. So let's talk about the things that actually matter. And the reason why these are the things that matter is they're the things that are actually data supported in interventions for cardiac arrest. High quality CPR without interruptions or with very minimal interruptions, the early defibrillation of shockable rhythms, and that we find the cause and reverse it. Things that we often waste time on: stopping CPR to get IV access, stopping CPR for an airway, taking too long of pauses for pulse checks and ultrasound, worrying about giving epinephrine, compression to ventilation ratios. One thing I can say, guys, is if we're thinking about whether to do 30-2 versus 15-2, then we're already about 30 years behind on cardiac arrest research. We really need to focus on the things that matter. So for instance, one of those is the perishock pause. Many of you guys learn when you're doing your ACLS courses to pause CPR and then make sure that everybody is away from the patient. Say, you're clear, you're all clear, everybody's clear from the patient. Sometimes that can really go on for an extended period of time. And we know that if the perishock pause lasts greater than 10 seconds, that it is going to double the chance of poor survival. So obviously it's different in that most cases in the hospital are going to be PEA arrest, which involves putting on our internal medicine hats and thinking about the underlying causes earlier. But I don't want to forget the fact that if you do have a shockable rhythm, it's important that we recognize it and intervene. Time to defibrillation really matters. So you can see there's a pretty precipitous drop in survival to discharge the longer we go in minutes to defibrillation for a shockable rhythm. So let's talk about roles. A lot of the most important parts, not surprisingly, fall on our residents. We call them to be the leaders. We ask that they focus on closed loop communication with all the other code responders, and that really they need to be the brains of the operation. They're the rhythm identifier for shockable rhythms, and they need to be the first to be thinking about H's and T's for PEA arrest. Now, interns might feel a little bit helpless, but they can actually be really important to the code response. One thing you can do is help your very scared resident by having the ACLS card out to help them have an easy reference point. You can monitor for effective CPR. In other words, be the compression coach. Make sure that we're limiting perishock pause. Make sure that compressions are effective. Make sure that pads are on. Open the computer and put in orders. Be the one to contact the ICU for transfer, and also to call family members to update them. I should also mention it's important for the primary team. So let's imagine a cardiac arrest is called on an inpatient who's on one of the resident teams. You know, it's important to be prepared to deliver the most important information about your patients so that it informs to the code leader resident that the information they need to best treat the underlying cause in the event of a PEA arrest. So I think this highlights the importance of a summary statement. One of the things I used to practice as a resident was I would try to identify the patients on my list who are at the greatest risk of a decompensation overnight. And I would think about how to deliver the most high yield information about this patient in the quickest way possible. I encourage you guys to start practicing that. Okay. So I'm a pretty simple guy. And if you guys look at the ACLS cards that they hand out, they're really pretty complicated. There's a lot of loops. There's a lot of focus on timing. Truthfully, I think you guys should feel unencumbered by that. And the reason is, you know, I pointed out earlier, there's only a handful of things that really matter when we're treating cardiac arrest. And so I try to think about cardiac arrest in this way to focus on those things. So first, I'll draw your attention to the blue box. Things that are going to happen on autopilot in codes at Emmanuel Hospital and Good Samaritan are airway management by the RT and the airway code responders. So at Good Samaritan, that's going to be the emergency room doctor. And at Emmanuel, that's going to be the anesthesiologist, okay? It's also true that giving a milligram of epinephrine every 5 minutes is one of those things that just happens. The pharmacists will be at the codes. They're going to be there driving this. Our really highly experienced RRT nurses are also going to be present. Don't worry about the epi. It's gonna happen, okay? So I think of, is the patient dead? Start CPR and place pads. As soon as pads are in place, we should see if there's a shockable rhythm. If yes, shock and continue to shock every 2 minutes until ROSC is obtained or you end up in the PEA pathway. If there is not a shockable rhythm, then continue CPR and start thinking about underlying cause. Include giving calcium. This is it, guys. This is really all we have to do to provide effective care in cardiac arrest. Notice the things that we have to focus on most are shocking when appropriate and thinking about underlying cause right away. Okay, I mentioned earlier not to worry about airway, and part of the reason is that there's really not good data to support the use of an advanced airway in cardiac arrest. This was a really large study that basically looked at thousands of cardiac arrests in hospitals across the United States over like a 10-year period. And they looked at the rate of intubation during the first 15 minutes of the resuscitation. And it actually shows that there was a trend towards improved survival in those patients who were not intubated. Now, I still think an advanced airway can be nice in the setting of cardiac arrest, but you should never pause CPR, again, the thing that's most important, in order to achieve an advanced airway. And sometimes you might have to butt heads with the anesthesiologist and the ED doc in order to achieve that goal, but know that you're doing the best thing for the patient. Okay, I was hoping that, I'm not sure if you guys can unmute, but I want to talk about PEA and asystole, and I wanted to see if we could go through and call out our H's and T's. So can you guys unmute and holler out some H's and T's, or you can also put them in chat, okay?
Tension pneumothorax.
All right, good, Forrest, I love it.
Tamponade.
Okay, tamponade.
Hydrogen ions.
Hydrogen ions, excellent. So acidosis. We got toxins. Okay, good. I'm seeing, so actually I see hyponatremia and hypernatremia. Those are actually not considered one of our causes of H's and T's, but I see hypo and hyperkalemia. Those are, that's excellent. Hypothermia, that's excellent. Thrombosis, good. Excellent, guys, thank you. Okay, so here's our H's and T's. I think you guys really were very comprehensive. So what I did is I just put dashes through 3 of them, and I'll tell you why. So hypovolemia, it is a cause of cardiac arrest, but the context that we frequently see it is through severe hemorrhage, and specifically a lot of trauma codes are associated with this, or it tends to be really severe GI bleeding is how we would interact with this in a medical context. So in other words, those are things that you're the underlying cause is going to be right in front of you, and you're gonna have to intervene on that. Hypothermia just doesn't really apply to in-hospital arrest. We definitely see cardiac arrest from exposure, but it's usually out of hospital, okay? We're probably doing something wrong if people are dying from hypothermia in the hospital. Hypoxia. Now, the reason I took that off is because, again, airway management is an essential part of intervening on the code. And, giving these patients 100% oxygen is going to happen on autopilot. Okay. So we're going to do a handful of cases now, and I want to talk through what is the most likely H&T for each of these. So I encourage you guys to just start answering this with the chat function, okay? So we got a 21-year-old woman who's admitted to the ER with DKA. Her initial vitals are notable for a heart rate of 130. Her lab work shows glucose of 450, creatinine of 4. She's got a K of 6.8, and her EKG shows widened QRS. She's given 2 liters of normal saline, sent to the ICU, where she immediately has a cardiac arrest. All right, what's the most likely? Good, I'm seeing a lot of hyperkalemias. Excellent. Good job, guys. All right, how do we manage this? Good.
Insulin.
Okay, so I'm seeing calcium, and Forrest said insulin. Good. So we manage this first with effective CPR, make sure the pads are on, and note that she's likely coding from hyperkalemia. So the manage for this in the context of a cardiac arrest is going to be calcium chloride. Now, I would love for the ability to have something that could, to use things like insulin or albuterol in order to shift potassium in the cardiac arrest. But the truth is that they tend not to work in that context. You need something that's going to be effective right away. And that's calcium chloride, okay? Now, if ROSC is obtained, then we would want to do exactly what Forrest said, which is bolus insulin, start them on an insulin infusion, and then consider some additional measures for shifting potassium. Oh, sorry, guys. Okay. So this is the case continued. Over the next 48 hours, she remains on an insulin infusion. Glucose is at goal, the gap closes, the team's anticipating an easy transfer to the wards, and they stop checking her labs. And just prior to transfer, she actually becomes bradycardic, develops a wide complex, and then loses pulse. What's the most likely cause now? Nice, I'm seeing Diana is the only one who's answered so far. Good. All right, guys. Nice. So, yes, hypokalemia. This is actually from a case that I saw, a patient who had cardiac arrest from hyperkalemia upon arrival and then hypokalemia later during their hospital stay. Oh, good. There's a question here from Claire. She wrote, why calcium chloride instead of gluconate? The main reason, Claire, is that the calcium chloride concentration is really high. So remember, 1 gram of calcium chloride equals 3 grams of calcium gluconate. And we want to give the highest amount of calcium in the quickest way possible. Calcium chloride is safe to push in the setting of a code, and it's in the code cards. So that's why we would use it. Okay. So remember, for DKA, these patients are actually total body potassium deplete. Giving insulin shifts the potassium back into cells. Their extracellular potassium is low and needs to be monitored really closely. I'm sure a lot of you guys already know that. So we manage this with effective CPR. We put the pads on and we give calcium, again, for the same reasons that we gave calcium for the hyperkalemia. This helps to stabilize myocardium. All right, so we're back to our H's and T's. We learned that we can adequately address hypo and hyperkalemia with calcium chloride. All right. We've got a 68-year-old man with bullous COPD who's admitted for hypercapnic respiratory failure, placed on BiPAP, and transferred to the ICU. Over the course of the next day, requires higher inspiratory pressures for an unresolving respiratory acidosis. Suddenly, he becomes hypoxic, hypotensive, and then loses pulse. All right, can you guys vote for me? Awesome. Nice, guys. Tension pneumo. How do we manage it? Always effective CPR, make sure the pads are on. And then this is where we're getting down into kind of the aggressive management that's required for getting after these H&Ts. And, you know, some of these are going to require mechanical fixes, and tension pneumo is one of them, all right? So what I would do is I'm just going to assume that most of you have never done a needle thoracostomy, and that's fine. I've done 2 in my entire career. But what you should do is call it out, okay? You're not going to be alone in these codes, and there's going to be a lot of people around you who can help to intervene on your behalf. So say out loud, I'm concerned about tension pneumo. Can anyone do a needle thoracostomy? And if you're alone, then this is actually a pretty straightforward and easy thing to do. We have 14 gauge angiocath needles that are available in the code cards. You'll insert them at the second intercostal space at the midclavicular line and slide the catheter into the pleural space. Okay. Next case. Yes, whoever wrote, I'm not sure if that was Sam or Kelly, you're allowed to do life-saving procedures in an emergency even if you're not signed off. Absolutely. And yes, John, there was an audible hiss of air. All right. 55-year-old woman, ongoing treatment for breast cancer on hormonal therapy, current smoker, admitted for extensive symptomatic DVTs. The vitals are significant for tachycardia with heart rate in the 140s. While the team is admitting the patient, she abruptly develops asystolic arrest. All right. What do you guys got here? C. Good. I think there's an agreement. Thrombosis. So how do we manage this? Again, effective CPR. Make sure the pads are on so we don't miss a shockable rhythm. And she's likely coding from PE. So what's the management of this? It's thrombolytic therapy. And so the way, we do not have TPA in the code cards, but we can have it brought up if you guys have a high index of suspicion that thrombosis, either PE or MI, is the underlying cause for the PEA or asystolic arrest. So the most important thing is we have to think about it early so that the pharmacist can have time to get it up to the bedside while we're continuing high quality CPR. One thing that we know about cardiac arrests from PE is that ROSC is exceptionally unlikely unless we're able to treat the underlying cause. We do have some data that suggests that giving TPA in cardiac arrest for patients who have a high index of suspicion for thrombosis can result in improved rates of ROSC, improved survival at 30 days. I would say that finding the data to support the use of TPA in terms of achieving improved neurologic survival is still elusive, but I think there's enough there to suggest that it's probably the right thing to do. Okay, so just to review, most common codes in the hospital are PEA. Most common causes are what we can actually treat. Hypokalemia, we give calcium. Hyperkalemia, we give calcium. Thrombosis, think about TPA early. Tension pneumo, if you think of it, say it out loud and then intervene. Oh. Okay. All right, next one, we have a 54-year-old woman with a history of schizophrenia, chronic pain, on methadone maintenance, admitted with community-acquired pneumonia, treated with levofloxacin due to a penicillin allergy. Course is complicated by agitated delirium requiring PRN antipsychotics. A code blue is called when the nurse sees this. What is that, guys? Good.
Torsades.
Nice, nice, good. What's the next step in the management following initiation of high quality CPR and pad placement? Okay, I see a lot of magnesiums here. Oh, Sean, I am so proud of you. You got it. Guys, don't forget, even polymorphic V-tach is a shockable rhythm, okay? So the most important thing is that we don't get over-focused on what the ultimate therapy is and know that these patients still need defibrillation, okay? It is true that actually all of these other interventions, magnesium bolus and infusion, and isoproterenol infusion, or placing a transvenous pacemaker emergently, might also be necessary therapies for treating torsades, but defibrillation is still the most important, okay? All right, I want to talk briefly about when to stop a code. This is a hard thing to do. These should be team-based decisions, meaning all these other people in the code team are stakeholders, and we should consult them. It should be informed by the patient's age, their comorbidities, and their presentation. And if you're thinking about it, then I can tell you that everybody else in the room is also thinking about it. So I'd say, if you're 15 minutes into the code and ROSC is not obtained, you need to start asking around, is there anything else that we might be missing? And say that I'm starting to think that we might not achieve ROSC and we should potentially consider stopping this code. Before we actually call it, I think it's important to ask the other people in the room, does anyone have any objections to stopping? Okay, so I wasn't going to get into the nitty gritty of how we use end-tidal CO2 in cardiac arrest, but just know that we do monitor it in the vast majority of these in any patient who is able to get an advanced airway in. If the end-tidal CO2 is less than 10 after 20 minutes, then you should stop the code. Neuro intact survival is unlikely to occur. Okay. So post-arrest care, transfer to the patients to the ICU, call your attending if they're not already present, check to see if the patient is following commands and complete a full neurologic assessment, and then update the next of kin if you have not already done so. So despite some controversy, we still do targeted temperature management for at least 24 hours after the arrest, even if it occurs in the hospital. We don't have any randomized trials that have evaluated targeted temperature management after in-hospital cardiac arrest, only out of hospital, but our current guidelines suggest that it's the right thing to do for at least 24 hours. So the way that we do it here at Legacy is we do intravascular cooling with a device called the ICCath, and that needs to be placed by either a fellow or an attending. In the meantime, though, you guys can ensure that the patient is reaching goal temperature by putting ice packs into the axilla and to the groin. What we know is after the period of performing 24 hours of targeted temperature management that we also want to avoid fever for the next 72 hours. Okay, so let's go back to our H's and T's here. So remember hypo and hyperkalemia, we want to give calcium chloride. And again, because there's no downside to giving calcium, it should just be a component of your PEA algorithm. It should just be given. For thrombosis, either PE or MI, we need to think about TPA early. Tension pneumothorax, needle thoracostomy. Cardiac tamponade, obviously we didn't have a case talking about this, but it also requires a mechanical fix. And this is another scenario where you just need to ask assistance from the other people who have potential experience in managing that. We also didn't talk about acidosis, and people often ask me a lot about the utility of giving sodium bicarbonate. You know, the truth is, in the setting of cardiac arrest, it probably doesn't help much. And the main reason is that bicarb has a really large volume of distribution. And so you'd have to give a lot of it in a cardiac arrest for it to make a difference. You know, if I think about it, often it's farther into a code. And what I'm trying to achieve is helping to correct the underlying acidosis that is going to be certainly present from a prolonged arrest. So maybe if I'm coding for a while, then I would give 3 or 4 amps of sodium bicarb, but it should be with the understanding that it's unlikely to fix the underlying cause for the arrest. Okay, guys. Just wanted to give you our algorithm one more time, just so you can see this. Again, this is how I think about it, and I encourage you to do the same. Okay, questions? Anyone? Euler?
I was just gonna say that sometimes you can ask for an ABG with all like the Kim panel and everything like that, instead of waiting to get all of your labs back to see what their K is or all of those things. And that ends up happening a lot quicker and can help narrow your like differential from what could this possibly be to, oh, their K is 7. And that's just a helpful thing.
Yeah, I think that's a good point, Forrest. I think that sometimes being able to get those labs is, it's not always a guarantee. And when you step back and you think about what are the things that cause PEA arrest that I can actually do something about, the primary intervention that we're going to utilize should just be given regardless, which would be calcium. So I think you're right. It helps to inform maybe the ongoing management should we achieve ROSC to prevent them having a recurrent cardiac arrest, but it's not essential for us to deliver the best care.
I was wondering is there any reason why we wouldn't use the Arctic chiller or whatever that thing's called?
The Arctic chiller.
Or the external cooling device?
Oh, the Arctic Sun? Yeah.
That's the one.
Yeah. So what we know about targeted temperature management is that it's really the goal temperature is more important than how you get there. So there's no difference in neurologically intact survival when you compare the different types of cooling devices. So be it intravascular versus surface cooling. So we use the icy cath just because it's what's been done for a long time. It's true that the icy cath can be helpful for people who have skin problems, and because we have a burn center, I think that's why the icy cath was sort of taken up at Emmanuel Hospital. It's also true for trauma patients. Sometimes it can be harder to put those pads on them. But in terms of outcomes, there's no difference in surface cooling versus intravascular. It's a good question, Sam. Okay, So guys, let's go back over the stuff that we talked about before. What percentage of people are going to survive post in-hospital cardiac arrest? This is all comers. Whoops. Oh, shoot. Lost my chat. Good, 25%, nice. What percentage of people survive post in-hospital cardiac arrest and go home or to a SNF? 12% go home, 6% to SNF, LTAC. Good, good. Nice. All right. What H's and T's do we see in hospital codes that we can actually do something about? Whoops. Hypo, hyper K, good. Tamponade. PE, thrombosis, MI, tension, pneumo. Good, guys, you got it all. Thank you for participating. Treatment for hypo and hyperkalemia? Calcium. Good. Treatment for tension, pneumo? A needle. Excellent. TPA. Excellent. Okay, guys, let's recap. What should all coding patients get in the hospital? Good CPR. This is the most important. A shock, if the rhythm's shockable. Remember, most in the hospital will not be. We need to think quickly about reversing the underlying cause. You guys are called to be internists in these codes. Epi every 5 minutes. Again, this is going to happen whether you call for it or not. A gram of calcium chloride. Remember, it won't hurt and it might help. If you think about PE or MI, ask for TPA and do so early. After a cardiac arrest, we're going to cool them to 36 degrees if they do not follow commands. All right, that's it, guys. Any final questions I can answer for you? So Chase said, how do you prefer to confirm pneumothorax? So the truth is, Chase, that we don't know that there's a pneumothorax oftentimes before we intervene with needle thoracostomy. So typically what occurs is this is a clinical picture. And one thing you have to remember, these patients are dead and they can't get more dead, all right? So nothing that you do in this scenario is likely to hurt them. What I would do if a patient's dead and you have a high suspicion, then I would do needle thoracostomy on both sides. So sometimes it is obvious and you can see things like tracheal deviation and you would want to go to that side, but you can also just do it on both sides. And again, even if you are going into a side where there is no pneumothorax, you're unlikely to cause one, and you could leave the catheter in place. Does that answer the question?